Lymphadenectomy. The need for extensive lymphadenectomy in patients undergoing radical nephrectomy remains a subject of debate. Despite the fact that multiple prior studies have shown that survival benefit with the lymph node dissection performed at the time of nephrectomy, recent EORTC 30881 showed distinct advantage. This trial represents level-1 evidence. Its generalizability is limited since the trial included significant number of patients with a low risk for nodal mets. Like 81% of these patients had grade 1 2 tumors and 72% had organ confined disease, which support the low incidence 4% with nodal mets found in the lymphadenectomy cohort. And more recently, Gershman et al. They're controlling for non-random treatment allocation using propensity score based analysis evaluated the impact on survival of lymphadenectomy on 1797 patients with non-metastatic RCC who underwent radical nephrectomy with or without lymphadenectomy, and on evaluation of their cohort the authors reported no survival advantage associated with lymphadenectomy. More authors assess the impact of lymph node dissection in several risk group categories using increasing threshold probabilities for presence of PN1 disease, noting a lack of added improvement in any of the survival measures, recurrence-free, cancer-specific overall. And in an effort to reconcile the conflicting data on survival benefit of lymph node dissection, Gershman et al. Examined the natural progression of the patient with completely resected N1 M0 RCC in a cohort of consisting of 138 patients of 5-year metastasis-free survival was only 16% with a median time to recurrence versus 4.2 months. And a small subtype of patients did achieve durable response. And on evaluation of their tumor characteristic, these patients were noted to have a more indolent tumor behavior like low stage, grade, and absence of necrosis and sarcomatous differentiation. So together, in patients who have N plus disease, and this finding suggests that lymph node dissections plays more important role in staging, diagnostic rather than a therapeutic tool. And the decision to perform lymph node dissection should be taken with caution and considered in a subset of patients like young patient, FH papillary type 2 tumors, and those considered for the adjuvant trials, given the majority of the patient will not benefit from this added procedure but may be subjected to the low but real risk of lymph node dissection associated with the complication. And cases where regional lymph node appear involved, in the absence of compelling data, the current standard of care is regional lymphadenectomy, and especially in M0 patients. Now, building a risk stratification and follow-up of localized RCC, the TNM staging system is the foundation for standardized and risk communication for all solid malignancies. The TNM staging allows disease standardization. Its broad category limited the ability to provide individualized risk stratification to help dictate surveillance schedules and eligibility for adjuvant therapies or clinical trials. And as a result, several clinico-pathological prognostic models have been introduced in the hope to provide improved risk stratification and individualized risk prediction. Three model UISS, SSIGN, and Leibovitch have become the pillars for RCC risk stratification in RCC. UISS, SSIGN, and Leibovitch. They becoming basis for surveillance and clinical trials eligibility, and the swift adoption of these clinical pathological prognostic models was a result of their improved discriminatory ability compared to the standard TNM staging, which was validated in several external cohort. And importantly, the development and validation of aforementioned models was in retrospective cohorts, which add significant bias due to lack of standard pathological and outcome reportings, and the inclusion of historical cohorts spanning several decades. And a recent validation of this retrospective prognostic models contemporary data collected as a part of the clinical trial, that is ASSURE. It showed a significant reduction in their discriminatory ability, with some of their models modestly outperforming standard TNM staging. And as a result, novel clinicopathological prognostic model was introduced by the ASSURE investigator using contemporary highly attenuated data with standardized reporting, limiting the bias of prior retrospective model. And the novel Nomogram is histology inclusive and provides three distinct clinically actionable oncological outcomes like OS, CSS, and early disease progression, with the added benefit of being agnostic to allow generalizability for future cohort. And the model is limited by its reliance on clinical and pathological factors, as others being currently utilized. Rini and colleague recently introduced the recurrence score, 16 gene panel consisting of genes associated with the vasculogenesis, cell growth and division, immune response and inflammation from nearly 1000 nephrectomy patients, and the recurrence scores were noted to be independent predictor of recurrence after stratification by stage and adjustment for tumor size, grade, and Leibovitz score. Additional risk score, recurrence score to other prediction nomogram will allow for an individualized biological risk assessment not available with the existing clinical and pathological parameters. And follow-up for cancer survival focus broadly on three: detection of the cancer recurrence. Wide variation in the recommended practice have led to the development of guidelines by various organizations. Both EUS and EU recently introduced updated surveillance guidelines that focus on a cancer adapted approach, and based on this clinical and pathology factor, both guidelines risk stratify their surveillance scheme schedule. Leibovitz prognostic model for patients with the clear cell RCC recently analyzed EUA guidelines for the follow-up of patients with localized RCC reflect a consistent approach that takes into account heterogeneity of the population of the cancer survivors. While most guidelines advocate surveillance for 60 months to 60 months, treating physician must recognize that up to 30% recurrence occur after 5 years. Up to 30% recurrence after 5 years. Now, role of adjuvant therapy for RCC. These are the AUA localized RCC. Low risk PT1 grade 1 and 2. Intermediate risk is PT1 grade 3 4, PT2 only any grade. High risk PT3 any grade, and very high risk is PT4 N plus. Sarcoidoid rhabdoid differentiation, macrophage macroscopic margin. So follow up for low risk, recommended follow up at a schedule after surgery for renals in months 3, 6, 9, 18, 30, 36. Intermediate 3, 9. Alternate 6 monthly follow up. For high risk, continue follow up. So for low risk, we will do annual follow up. Intermediate, we will do 6 monthly follow up and then annually. For high risk, 6 monthly and then annually thereafter. Significant proportion of patients are cured and remission after surgical treatment for localized RCC. Distant mets, they are detected in 20 to 35%. Local recurrence in 2 to 5% of the patients, and patients with locally advanced RCC, others high risk features, they are at greater risk of recurrence, and various predictive tools that can be provide individual estimate. And despite the significance likelihood of recurrence in patients with poor risk features, multiple therapies have failed to demonstrate improved survival in adjuvant setting, and prior trials have evaluated hormone therapy, radiotherapy, immunotherapy, tumor vaccines, all with essentially negative results. And the success of targeted molecular therapies in metastatic RCC have supported their role in the adjuvant setting with several randomized trials. Assured trial was first trial. Assured trial first to evaluate the efficacy of the tyrosine kinase inhibitor in the adjuvant setting. They included around 2000 patients of high risk T1B grade 3-4, PT2 T3 N1 clear cell, non-clear cell RCC, randomized to sunitinib, sorafenib or placebo for 12 months following complete surgical resection. And the high rate of treatment related discontinue with results trials were released showing no difference in the disease-free survival, 5.8 year with the sunitinib, 6.1 year with the sorafenib, and 6.6 year with the placebo. Then ASTRAC. So first is ASSURE trial, then ASTRAC. They randomized patient to sunitinib. Positive results were reported with the median DFS 6.8 years with the sunitinib and 5.6 years with the placebo. ASTRAC, like ASSURE, had a relatively high treatment-related discontinuation rate of 28%. 48% patients treated with the experience have grade 3-4 adverse events, and despite the lack of benefit of in overall survival in ASTRAC, recently FDA approval for their adjuvant use of sunitinib in high-risk kidney cancer after surgical resection. Recently, PROTECT trial. So third one is PROTECT. PROTECT trial, adjuvant pazopanib. Pazopanib, higher dose 800 mg of pazopanib. Unfortunately, only 26% patients were able to tolerate this high dose, and with the remaining to be reduced to 600 mg, and this 600 mg showed no difference in the DFS at the median follow-up of 30 months. Encouraging results for the immune checkpoint inhibitors in advanced RCC has prompted the use of this in the adjuvant setting. And prosper trial. So prosper trial is a special interest for patient with harness a possible immune priming phenomenon. Keynote 564 compared pembrolizumab 1 year versus placebo. Improvement in the treatment arm at 2 years and leading to FDA approval. And secondary analysis, younger patients presenting with the metastatic disease with PD-L1 positivity likely to be benefit from the treatment, and in the absence of improvement in the OS, it remains to be seen if adjuvant with the pembrolizumab may lead to significant change in RCC survival, especially given the transition to combination regimen in systemic setting. The correlative results of the PROSPER trial have potential also give insight into the ideal sequencing of intraop therapy and nephrectomy in patients at high risk of recurrence, in addition to providing possible predictive biomarker of response.